Welcome to Healthcare Upside Down with your host, Dr. Nick Vanterhaden, and brought to you by ECG Management Consultants. You can learn more about the show on the program's page at healthcarenowradio.com or on our blog at ecgmc.com/HUD. The U.S. spends more on healthcare per capita than any other country on the planet. So why don't we have superior outcomes? Why haven't the principles of capitalism prevailed? And why do American consumers have so much trouble accessing and paying for healthcare? Each week, Healthcare Upside Down will dive into these and other issues with ECG principal Dr. Nick and guest panelists as they discuss the upsides and downsides of healthcare in the US and how to make the system work for everyone. And we end with your better pill to swallow, the conclusion to today's episode with insights on challenges and changes that improve healthcare. Now here's your host, Dr. Nick.
Health screenings are an important part of maintaining good health, especially as you get older. Many deaths could be prevented if people got simple, regular health screenings as recommended by their doctors. In the United States, we are fortunate to have a number of health screenings that can detect problems early. Why is that important? Because early treatment for most diseases is more likely to be successful. The later we catch a disease, the harder it can be to treat or cure. For example, colon cancer is one of the most preventable types of cancer, but many times, few symptoms occur early when it's most treatable. A routine exam can detect a colon polyp before it becomes cancerous, and it can be easily removed. But in the US, some 20% of people are not up to date on the recommended screening for colon cancer. Breast cancer is similar, with a lack of detectable symptoms early, and the rates for breast cancer screening are similar, with as many as 25% of women reporting they are not up to date with their recommended screening for breast cancer. Rates vary by patient group and are further hampered by racial divides and inequity that play an economic and ethnic contribution to individual opportunities and uptake. Healthcare screenings remain a center stage of the delivery of good quality healthcare, and despite some great progress in the prevention, detection, and treatment of breast cancer, we still have plenty of opportunities to improve outcomes and break down the barriers to increase access and improve uptake in all groups. When you get the health screenings recommended for you, you're taking a simple but very important step toward a better quality of life and quite possibly a longer life. So how do we improve the availability and uptake for breast cancer screening? Join me on the Healthcare Upside Down show as I talk with Dr. Amy Patel, a breast radiologist, assistant professor of radiology at the University of Missouri, Kansas City School of Medicine, and chair of the American College of Radiology Advocacy Networks, and the president-elect of the American Association of Women in Radiology. Hi, Amy. Welcome to the show.
Hi, thanks for having me.
So it's Breast Cancer Awareness Month, one of the primary methodologies for screening. And screening has, I would say, brought about something of a revolution, a positive revolution in the treatment and care and actually prognosis of breast cancer is mammography. But I've got to be honest, I hear a lot of complaints about it, both as an experience and, the whole sequence. Why is it we do mammography? Is it still the best choice?
Yes, so at this time, the only screening tool with a proven mortality benefit is mammography. And we know since the advent of breast screening programs in the United States, which launched in the early 80s, we've been able to reduce breast cancer death rates to almost 40%. So it is the mainstay, and we've done a great job at advancing mammography in general with the advent of digital breast tomosynthesis, which is now, in layman's terms, 3D mammography, which is now deemed no longer investigational and truly is the mainstay of many of our practices because of the fact that we're able to look at the breast tissue in a three-dimensional way, sort of like turning pages of a book book. We're able to scroll through the breast tissue, similar to a CAT scan. And if there is a cancer that is hiding, particularly in a sea of dense breast tissue, which appears white on the mammogram, we're more likely to detect it. So we're seeing an increase, not just in our cancer detection rate, but our invasive cancer detection rate, which is very important when we look at prognosis. So for us, mammography truly is the mainstay, but of course there are supplemental screening measures that are coming out more and more in our field that, provide different avenues for patients in this era of what we call personalized breast care.
So I think there's not a month goes by that we don't hear some story, particularly of high-profile individuals who've been through screening, are actually quite grateful for screening. I think there's even a recent one I just saw in the last week or so with one of the newscasters. Given that 40%, I mean, that's good, but is it good enough? And how do we get better? And what should we be thinking about from a screening strategy?
Sure. We've made great advancements and we should be very proud, but the work is far from over. And for those of us who are in the trenches facing this every day, we still have immense challenges. In certain parts of the country, anywhere from 20 to 40% of patients are still not receiving the screening that they need. And this is not just applicable to mammography. We're talking about CT lung cancer screening, which is likely a higher percentage, colonoscopy screening. So screening in general, we need to do a better job at reaching these patients. But another part of it is just access. Unfortunately, we do not have, federal legislation that's sweeping to cover all types of breast imaging modalities that a patient may need. And largely, a lot of this legislation occurs at the state level. Now, we've made some great advancements, particularly through the PALS Act at the federal level and extending the moratorium for annual mammography screening beginning at age 40. But that is just one part of many, specifically patients who don't have insurance, specifically the underinsured. And so many states are really trying hard for access. In the state of Missouri, I was very honored to be a part of passing legislation in 2018 and 2020, both for average risk and above average risk patients. But that's just for women who have insurance through the state of Missouri. So let's say you're a patient who has insurance, who lives in Missouri, but it's based out of Tennessee, you're not going to have the same coverage benefits as a patient in Missouri. Or if you're a patient who doesn't have insurance, period, that's another bag of worms, a whole can of worms. And so we definitely have a lot of work to do when it comes to reaching patients, and specifically when it comes to women of color. There are many states throughout the country, unfortunately Missouri is one of them, with one of the highest breast cancer death rates in Black and Hispanic women. And one of the counties which plagues this is the county in which I was raised, in rural Northwest Missouri, called Livingston County. So those of us who are in a position to try to push for change, I'm a fervent believer that we should. We should be proud of what we've accomplished, but the work is far from over.
So I think some great points there in terms of we've made progress, but clearly not enough. I think this inequity thread continues to permeate almost all of the discussions I have in healthcare and on this show. And as you think about that inequity and addressing that inequity, you've got one state, albeit, that's the insurance element, but one state, some others down. What is the pathway to fixing that inequity? I mean, we really want to see this and I assume that the access is because, or the lack of, utilization is because of lack of access. Is that the case? And then how do we reconcile and deliver this access? Is it about mobile clinics? Is it about geography? What are the elements that you're working on to sort of reconcile this?
Sure. Access is a large part of it, of course, but really education should be discussed as well. So truly, it will take a multifactorial approach if we're ever going to close the gap to breast care inequities in this country. We know that health literacy rates vary significantly throughout the country when you look specifically at urban versus rural, or even geographically, where I practice now in the Kansas City, Missouri area, serving rural patients all the way up to southern Iowa, comparatively to where I was practicing in Boston, Massachusetts, previously in my first year of practice. So there's a lot of disparities there, particularly from a health literacy standpoint. And so education is important. And honestly, I feel like a boots on the ground approach is important. So I do a lot of work where I'm going out into rural communities, talking to members of the community at luncheons, at breast cancer awareness events, in churches. I mean, anywhere we can go to educate these patients. And invariably from these sort of activities, I do have patients that will come up to me, or people come up to me saying, I don't know, I need a mammogram, I can't afford it. And we're able to plug those patients in. So a lot of it is just the awareness, it is the educational aspect, and then identifying these patients to get them the access they need. But in addition, there's other layers to this. So, for example, in the state of Missouri, we have a program called the Show Me Healthy Woman program. And this is a program that if you are a woman who's at the 200% poverty level, you can qualify for that program and to receive free cervical and screening mammography examinations. And then if you end up having a breast cancer diagnosis, you will be covered under BCCT Medicaid for your oncologic treatments. We're lucky to have this program, but even the program itself, there's still areas where it's difficult to become a practice or institution to even qualify to be a Show Me Healthy Woman provider. So in the state of Missouri, we're working on improving that for practices and institutions so they can have access for any patients that come in the door and they don't have to turn them away. But not all states have a program like that. So that's another avenue where states really need to look at and see if there is something of a similar variety that they can offer as well. But at the end of the day, having a federal setup would really be wonderful for our patients so that every state is not left behind when it comes to these patients, regardless of geographic distribution.
So I think great progress, and I agree with you. This boots on the ground acceptance, meet people where they are is one of the sort of essential elements to really bringing people along. One of the privileges I had was interviewing a group that essentially used the barbershop as a focal point for men in this instance, although, there's a part of me that's wondering, is there an equivalency that maybe works for women? I don't know as much about that side of it, obviously, but, I think that's part of the sort of approach. Are there other elements to this? I mean, let's be frank. There's not a woman I've spoken to about this. And obviously, I come at this with a little bit of humbleness. I'm a man. I've not experienced it, but I understand what the experience is. It's not a very pleasant experience. Is that something that we can address and improve on? I mean, where do you think that's going?
Well, the technology itself has improved patient comfort. No woman likes to have a mammogram. And, we have to, unfortunately, apply adequate compression to the breast to splay the breast tissues so that if there is a cancer hiding, we're able to detect it. I mean, that's just, unfortunately, how it is with a mammogram. However, with the advent of digital breast tomosynthesis, we're able to apply less compression, which comparatively speaking to the previous 2D or full field digital mammography. So there's less compression involved. And also just the compression paddles that are being used when a woman is having a mammogram. There's certain technologies out there where it can conform to the breast contour, which can also mitigate discomfort. I myself a few months ago, I had a mammogram, and it was obviously a very unpleasant experience when I was having it, but it was very, very short-lived. It was just a few seconds per image, and I was done. And so, and that was it. I didn't have any pain afterwards or anything like that. Other things that we can recommend is specifically taking some sort of pain reliever prior to your mammogram, if it's okay with your primary provider and your medication history. So I would say overall, the discomfort that a patient feels when having the mammogram is very, very short-lived, and the pros definitely outweigh the cons in terms of getting your mammogram, because the alternative could be, of course, lethal if you don't have your mammogram, and unfortunately a cancer does appear that is more advanced than when we could have detected it when it was less than a centimeter in size, where your survival probability approaches almost 100%.
Yeah, so I'll talk about it in the context that I can understand, and I think you're exactly right. It's, short-lived. It's certainly shorter-lived than the colonoscopy preparation that people undergo, and that's an essential part of screening, and certainly something I've been through more than once. I accept that as part of the risk-reward equation. One of the things that struck me about colonoscopy, and I think we saw an uptick, I want to say it was Katie Couric, who went through a very public sort of exposure and experience to say this is the right thing. Do you think there's some potential perhaps to do some of that, to bring people along, to show them, to your point, it's short-lived, and, the outcome of this is incredibly important and very positive?
Yes, particularly, public figures, those who are very respected, well-known, if they have gone through this, or even if they are, staunch supporters of getting their mammogram every year, we need these voices heard. Katie Couric is a very respected journalist, and we are very grateful that she has shared her journey. It's not easy. She was very brave to do so. It's a very sensitive, intimate time of one's life. But if more people can express and exhibit that bravery and tell their story, you could save so many lives. You have no idea the lives you'll touch. So for her to come out and impress upon the world that annual screening mammography is incredibly important, and she mentions that she was late by 6 months, and she shudders to think if she would have delayed her imaging even longer. So the more these public, well-respected figures can get out there and talk about their story, I do think it makes an impact in the community, and it spurs others to get their mammographic imaging if they're late on it or have never even received a baseline examination and they're of age.
Yeah, I'm a big fan of that. Meet people where they are, and also talk to them from the respected voices. And everybody has different sort of channels that they approach. It would be a missed opportunity if we didn't get you to state as clearly as you could. What are the specifics that women should think about from a mammography screening standpoint? When should they start? What is the frequency? What are the sort of the positive outcomes that can be expected from that process? And, statistically, it would be also helpful, I think, for people to understand what their chances are.
Sure. Well, we now recommend, first of all, that any woman of any color is risk assessed by age 30. So now we're really looking at risk stratification with women in this era of personalized breast care. So if you are a woman who is 20% or greater lifetime risk, you're considered above average risk or high risk. And that is different from an average risk patient. If you're an average risk patient, we recommend annual screening mammography beginning at age 40. Studies have shown the most lives are saved when you start screening at 40, the most life years and lives saved. So in addition to that, if you're average risk, and particularly if you have what's called dense breast tissue, where we see more of that white on the mammogram, as the density increases in a woman, the sensitivity of mammography decreases. Now, digital breast tomosynthesis has been wonderful, as I previously mentioned, particularly for women with dense breasts, but sometimes that is not enough. And so there are women that do elect to have supplemental screening modalities, such as ultrasound or something that we offer at our breast center called abbreviated breast MRI, which is an abbreviated MRI study that can look through those dense breast tissues. Many studies are showing commensurate cancer detection rates to full breast MRIs. It's also a cheap way for patients to have access to supplemental screening, as most institutions that offer abbreviated MRI right now just do it via cash pay because there is no specific code for that for billing. So that's on the average risk side of it. But if you're above average risk, we actually recommend breast MRI annually from the ages of 25 to 29. And then once the patient turns 30, we recommend they start mammographic screening, alternating every 6 months with that supplemental screening, as I mentioned. So we are doing this, as the studies are evolving, as research is evolving. We need to get more aggressive about diagnosing breast cancers in younger women. It's been incredible to see the changes, I think, in breast imaging in just a short period of time, the last 5 to 10 years. So that's what, a lot of us recommend in practice. And it's, again, very important that patients go somewhere where they can be properly risk assessed to know if they are high risk or average risk, so then they know what imaging surveillance they may need.
I think excellent advice. And, that personalization is definitely something we're seeing generally in medicine. We're moving more to, you're not just a diabetic, you are Nick the diabetic, and we customize things. And I think that risk stratification extraordinarily important. As we think about that whole process, there's obviously some folks that fall out, and there's identification. Just share a little bit of what that means in terms of the positive outcome. It's not something that everybody wants to hear, but the reality is that it's important to hear, and it's important to hear early.
Well, risk stratification is incredibly important because if we can identify those who are above average risk and we can then provide the heightened imaging surveillance they need, we're more likely to detect cancers early, which can lead to an increased survival probability. Same with genetic testing. If there's a patient with a strong family history who needs to be genetically tested and they do end up having a positive breast cancer mutation such as BRCA or CHEK2 or the myriad of mutations out there, then they can consider, perhaps I want to have a bilateral prophylactic mastectomy and reconstruction and reduce and prevent me from getting breast cancer. So it can be a very scary thing to face this and to be risk assessed and to know you're above average risk or to know you have a mutation. But as I like to preach, I really try to implore upon patients to take charge of their breast health, to not be afraid, because it can be very empowering, as there are certain factors that if we know what our risk is, then we can take the necessary precautions ahead of time. And that in and of itself can be incredibly empowering for patients.
So I think if I was to try and summarize this, it's that personalization of risk stratification. There's a part of me that, historically, the answer from a screening standpoint, yes, get your mammogram 40 plus once a year. But, as you eloquently described, that's not the case. It might be for you, but it might be different for somebody else. It's important to have this discussion with your primary care provider and obviously specialists as necessary. Highly variable based on all of the inputs, the family history and so forth. But the good news is we have many variations on a theme that can bring about a very positive outcome that can already improve on something that is, to this point, I think delivered some great value and some positive impact for breast cancer. So, Amy, thanks for joining me today.
Oh, thank you so much.
Traditionally, we would think of screening as a one-size-fits-all. But as you've heard from Amy, this broad brush approach has been replaced by a far more targeted and personalized risk stratification. Screening programs need to be customized, not just based on the clinical assessment and your personal risk measures, but also on your geography, your level of access, and delivered to the population where they are. Your better pill to swallow is it's not enough to offer breast screening. We must go the steps further to customize the message and the access to engage with patients through the media and communities they live in. The science and benefits are clear for mammography and the extended personalized screening, but that message needs to reach all members of our communities, together with widespread access to bring everyone to better health and better outcomes. Thanks for joining me, your host, Dr. Nick, on this week's edition of Healthcare Upside Down. Until next week, keep solving the business of healthcare, as if your life depended on it, as one day soon, it will.
That's all the time we have for today. You can find all of our episodes on your favorite listening platform by searching for Healthcare Now Radio. Also, check out our blog at ecgmc.com/HUD for summaries and commentary from each episode. Follow our show's social hashtag, HCUpsideDown. And join us each week as we work to solve the business of healthcare for everyone.